better sleep, sharper focus, a healthier life. It all starts with how you breathe.
Welcome to the No One Told Me, the Airway Health Connection, the untethered way, where better breathing meets better living. I'm Dr. Maggie Graham.
I'm Dr. Liz Turner.
We're the co-founders of Untethered Airway Health Center,
on a mission to help you breathe freely and live fully through proactive airway health.
Whether you're a dentist expanding your airway expertise,
or a family looking to sleep and breathe easier,
you're in the right place.
Each week, we'll bring you bold insights, real-world stories, and expert tips.
All to help you take control of your airway health. Because when you breathe better, you live better. Let's get started.
Hey guys, welcome to No One Told Me, the Airway Health Connection podcast. I'm Dr. Liz Turner. Today we're going to talk about tonsil and adenoid enlargement and how it relates to expansion. And also, there's a lot of confusion about tonsil and adenoid enlargement. What are the tonsils for? What are the adenoids for? Why do they get enlarged? And what do we do about it? Surgical, not. There's a lot of controversy and confusion out there, and I hope that you can glean some helpful information here. So I can do a deeper dive on this someday, but really what I always like to tell families is health is so multifactorial. We have genetics, we have what were given to us in our genetics for how our jaws will grow, and then we have the environment that surrounds us. We have the food we eat, the air we breathe, and those things can influence growth. They can also influence soft tissue. So why do tonsil and adenoids get enlarged? They're immune tissues and they trap bacteria, virus, allergens, irritants. They can enlarge from infection, allergies, reflux, chronic irritation from breathing patterns. So we can't say that mouth breathing causes tonsil and adenoid enlargement. We cannot say that it causes it, but we can say that it contributes. Because if we are mouth breathing versus nasal breathing, and we see this in dental tissues too, we see it in gingival tissues. If someone's mouth breathing, that gingival tissue is going to be more red and irritated. And we see it in tonsils. So they can be more red and irritated in part from the mouth breathing. Why else could they be? Okay, so breathing, nasal breathing is important. Nasal breathing is essential to health. Nasal breathing, it releases nitric oxide, which is a vasodilator, and it helps keep oxygen going to the tissues and to the brain. Nasal breathing also is more passive breathing. It's less turbulent. It's like an airplane in turbulence is the way I describe it. The more mouth breathing that occurs, the more turbulent that plane is going through the air, meaning more stress that it's under, right? If you had an airplane that was constantly in turbulence, you would expect at some point a screw becomes loose. That structure is under more physical stress than if it was going through clear air all the time. It's the same thing with the soft palate and with the tonsillar and adenoid tissue, because if we are mouth breathing, we'll see more irritation in the posterior pharynx. We'll see a drapier soft palate, in part because of the airflow. Why else would the soft palate be drapey? Because the maxilla, the upper jaw, is narrow. The soft palate there's the hard palate, which is the bone, which is what you think of when you think of a skeleton. It's what we're kind of truly expanding when we talk about expansion. And then we have the soft palate, which is a piece of soft tissue that's connected to the hard palate. Think about it like this. If you have a trampoline, you want it to be stretched on all sides. And that's what the soft palate should be. It should be stretched on all sides. If that trampoline frame collapses, the trampoline tissue, the bouncy part, will also collapse. So if that trampoline frame, if the skeleton is to collapse, the soft tissue will also be drapey and longer. What's the point of the tonsils? They're super active in kids and they peak in size about age 3 to 4. That's when their immune systems are really kind of learning. And exposure to new bacteria and viruses can cause some swelling. So we expect them to be a touch more enlarged in a 3 to 4-year-old than we'd see in a 7-8-year-old. But over time, as this immune role diminishes, the adenoids especially can start to shrink a little bit more naturally. Other things like chronic infections, repeated colds, strep, sinus infections, ear infections, they can make the tonsil and adenoids stay chronically enlarged. And low-grade inflammation from things like mouth breathing can contribute to the worsening of that inflammation. So I talk a lot in my practice about the tipping point. Like, what is the tipping point? Well, for some people, it's they get a cold in the wintertime and they just can't kick it. Like maybe they've been fine. But you throw in this perfect storm of a narrow jaw, the perfect storm of mouth breathing, the perfect storm of unfiltered or filtered air that we breathe in the wintertime in our daycare facility, and they get a cold and they've been fine. That cold is what tips them to a point where they're no longer fine. And then people start asking questions. The chances that the tonsils were enlarged before that is high. It's just they were never as symptomatic. Other things that can cause it: allergic inflammation. So things like environmental allergies, dust, pollen, mold, pet dander can inflame the adenoids and tonsils and keep the nasal tissues, the turbinates, a bit enlarged. And the thing is, children with untreated allergies can present with both nasal congestion and enlarged tonsils and adenoids. So what came first? Was it the allergies that contributed to the tonsils and adenoids, the turbinate inflammation, or was it the turbinate inflammation, the adenoids and the tonsillar tissue that were too enlarged to do what they were supposed to that contributed to some of the allergies? It's hard. There's no right or wrong answer because it can be so different in every single one. What else can cause it? Well, mouth breathing in particular, it dries and it irritates the tissues. If you mouth breathe at night and you wake up and you're like, oh my gosh, my mouth is so dry, that's what's happening to that lymphatic tissue too. And so this mouth breathing, it can dry and irritate the tissues. It can trigger some enlargement. Again, not causative, but contributing. And then things like a narrow palate, a retrognathic or retruded mandible, low tongue posture can also worsen the obstruction because, and I'll get to this in a moment, but we'll talk about jaw shape. And one thing I really like to bring some information to is reflux, because reflux I think is so misunderstood as to where it comes from. We just think it's GERD. It's not symptomatic, so it's not GERD. It's who knows, maybe I drank too much soda water. Reflux can come from a different place. It can come from the upper airway too. And so think about the tonsils and the adenoids like this. The breathing tubes need to be patent. They need to be open. The nasal breathing especially, and the oropharynx especially. Those are the breathing tubes. Nasal breathing should be passive and gentle. If we have inflammation and irritation from birth, that spiral of enlargement can either begin at that time or kind of start low and continue to worsen based on the environment around us. What do we see a lot in babies? So in babies, we see a lot of reflux. We see a lot of reflux because there's air being taken in. We see a lot of reflux because of a tongue posture issue, a tongue strength issue. We see a lot of reflux because of dietary. If that reflux continues and contributes to inflammation in the posterior pharynx and there's aspiration in the nasal cavity, of course, those tissues are going to be irritated. Then couple that with nasal blockage from that reflux, chronically congesting the nose, and we'll see a mouth breathing pattern begin. It's called the cycle of oral dysfunction, and it's something that's extremely important when we consider growth. So say we've got tonsils and adenoids that are enlarged because of why? Who knows? Mold, irritation, reflux, could be any of it. If they're big, they're big. What do we do about it? Well, depends, because each case is so individual. Sure, every kid in a perfect world would have an ENT consultation. But just like dentists, no two ENTs look at things the exact same way. We're not looking at things with the same vision. We're only looking at the structure at hand. So we're assessing those tonsils and adenoids. We're saying they're 90% obstructive. They're grade 1, they're grade 2, grade 3. The problem is when we're only looking at the size of the tonsils, for example, we're not looking at the structure that they're living in as well. Because one reason they can be grade 3 or 4 where they're really tight and touching is that the jaw and the airways themselves are restricted. And so if we're not considering the environment that the tonsils and the adenoids they live in, we're not really looking at the whole picture. Because why does that matter? Well, there's a concept of breathing and reflux called laryngopharyngeal reflux, LPR, and it's really misunderstood. It's upper airway reflux. Upper airway reflux is something that affects 40% of women. We're more likely to have it because our airways are more collapsible. When we have turbulent airflow that isn't passive through the nose, when we have an inspiratory flow limitation, if we think about taking a sip through a coffee straw versus like a McDonald's straw, to create pressure on that straw to draw fluids up, it takes a lot of effort. On a McDonald's straw or big Starbucks straw, it's a little different. It's very passive. When we have the same thing happen with airflow in the nose, if the airflow is compromised, if it's inspiratory flow, if it takes a lot of effort to drop that air, well, the nose doesn't collapse. There's a little valve here called the internal and external nasal valve, and it's a one-way valve. That sure can collapse. But most of the time, it's not going to collapse completely because the nose is made of cartilage and some soft tissue, so it's got a little bit more stability than what's down below it, the oropharynx. So the oral airway is a collapsible tube, and that's where stuff gets hairy. Because if we have that inspiratory flow, think of it like a hose with a kink in it. If we have that really aggressive airflow that needs to happen in nasal breathe, what happens is it forms a kink in the tube later down the chain. And our body's desire is to breathe, so it'll open up that tube. And I'm simplifying this just as much as possible because it's really hard to understand. But basically, poor airflow in the nose leads to kinks in the airway tube, which can then draw up stomach acid. And it doesn't feel like gastric reflux because it's not. So it's different symptoms. A lot of times it can lead to clenching, and that can lead to some jaw pain. It can lead to hoarseness or difficulty clearing the throat. It can lead to the constant need to clear the throat, like like that type of thing, a phlegmy, because there's a chronic pattern of irritation that's occurring in the back of the throat. And in children, different than adults, we're gonna see more chronic enlargement of the tonsils and the adenoids because they're meant to be filtering. Well, the problem is if they've got this external irritation from acid, of course they're gonna be a little bit bigger. So no, I don't think that mouth breathing alone causes tonsillar and adenoid hypertrophy. But I think we're being ignorant if we say it doesn't contribute to it. So now let's touch on expansion for a minute. So there are ENTs out there that are saying, like, dentists are promising we can shrink tonsil and adenoids. Well, we have literature that shows we can, in many cases, get statistically significant reduction in the size of tonsils and adenoids with expansion. Are we shrinking the tonsils and the adenoids? Maybe, but not in all cases. What is actually happening? Well, what happens when we expand? When we put in an expander that gets skeletal expansion, when we expand on the cranial bones, what we see is that we're going to widen the nasal floor. Like, the intent of expansion is to make more room for the teeth. This is a dental problem. The side effect of treating this dental problem is we're widening the nasal passages. And in turn, we can untrap the lower jaw and naturally, in some cases, bring it forward because we unlock the upper jaw. So I tell people the lower jaw is like the head, the upper jaw is like the hat, and the hat is too small for the head. The hat needs to be sized up in most cases. There's mid-face underdevelopment. The mid-face is the sinuses and the nasal passages too. It also houses the upper teeth, the maxilla. So when we widen the maxilla, we widen the nasal floor. We increase the volume of the nasal cavity, and not pathologically, we increase it to a size that's more favorable. Because if the teeth aren't going to fit, the nose is more narrow than it was designed to be. Like, the teeth weren't like, nobody went in there, God didn't go in there and be like, I guess I'm just going to design these teeth way too big and then just laugh about it later. It's really that we have this epidemic of underdevelopment of the jaws, and we need to expand the jaws. And no, this is not the only thing that needs to be done. We need to improve on the way that we breathe. There's a big conversation about if we don't work on the breathing patterns, not just where the tongue is sitting, not just how we swallow, but our brain's drive to get oxygen, because there's like this whole CO2, O2 imbalance. And the longer this goes on, the more pathologic it can become. So when we widen the upper jaw, we in turn allow the lower jaw to come forward, and we're really increasing the oral volume and the nasal and oral pharynx volume. And is that enough to avoid surgery? Not in all cases. But I have a set of skills in my practice that an ENT doesn't. An ENT has a set of skills in his practice that I don't have either. I think we all need to just work together, because if we look at some of the studies that show us what happens when we take out tonsils, well, at 12-year follow-up, the people are still symptomatic. The snoring is still present. Essentially, the procedure was a failure. It helped for a little while, but there was relapse. And the relapse occurred because part of the root of the problem is that the jaws are underdeveloped. The skeleton is too small. So tonsil and adenoids coupled with expansion, at follow-up, those people did not have symptoms that were so significant in comparison to their counterparts who only had the TNA done, because we address both factors. So we need to address both factors. What can't we control though? We can't control if a parent says no. We can't control if a parent has medical insurance or the ability to pay for dental treatment. Maybe I've got a family who's got medical and no dental. I still want them to address one of the two factors and get rid of the tonsils and the adenoids if they're blocking it, because we know in the literature that's the best way to open up an airway and the quickest. Is it the most stable long-term? Not without expansion. Maybe I've got a family though who doesn't have medical insurance and they can afford an expander, but they can't afford the tonsil and adenoid surgery. Or maybe they're more on the holistic side and they believe strongly that we're taking away part of the body's immune system. I can't control their beliefs. I can only educate and make suggestions. My recommendation is to always meet with ENT. Explore all of your options, because we all want to work together to help heal your child as well as we can with the structures that they have. But just because somebody says no to tonsil and adenoid surgery doesn't mean that I'm going to say no to expansion, because they have a dental problem that needs to be treated. And if in a few cases we can avoid surgery, awesome. If in a few cases parents still end up needing surgery, I already talked to them about that before. And if in many of the cases I can continue to collaborate with my ENT colleagues to make and bring better awareness to this space, that's what I want to do 100% of the time. So tonsil and adenoids can become enlarged for a variety of reasons. I do think mouth breathing contributes. Expansion can play a role in helping improve the structures of the airways, but we also can't overpromise that we can avoid surgery. But ultimately, a parent's decision for how they treat their child is up to them, because they're in charge. We're just here to educate and provide the treatments that we can and collaborate with our colleagues to make sure they get the best possible interdisciplinary care. So that's my 2 cents, and we'll see you next time on No One Told Me, the Airway Health Podcast.
Thanks for tuning in to the Untethered Airway Podcast.
If today's episode helped you see things differently,
Please share it with someone who would benefit from hearing this. And don't forget to subscribe.
Want to learn more about airway health or connect with our team?
Please visit our website, untetherediirwayhealthcenter.com, or follow us on Instagram @untetheredairway.
Until next time, bye!